This podcast is sponsored by BetterHelp. After experiencing trauma, I went to therapy, and my therapist guided me through a difficult time in my life. They helped me understand what was happening and provided me with tools to cope and find my own strength and resilience. Their experience and compassion were invaluable and enabled me to rebuild my life and move forward. I strongly believe in the power of therapy to help people through difficult times. BetterHelp connects you with a licensed therapist who is trained to listen and give you helpful, unbiased advice. First, you go to their site. You can use my link, betterhelp.com/resilience. You answer a few questions, and BetterHelp will match you to a professional who has years of experience helping people with struggles just like yours. Let BetterHelp connect you to a therapist who can support you, all from the comfort of your own home. Visit betterhelp.com/resilience or choose podcast, then notes on resilience during sign up and enjoy a special discount on your first month.
Not only are you dealing with the emotional aftermath or physical aftermath of some event, but you're now sort of being turned away as you try to connect with other people, or having to bear it, or feeling like you have to bear it on your own.
Hello, and welcome to Notes on Resilience. I'm your host, Manya Chilinsky. My guest today is Dr. Jordan Smoller, a psychiatrist, epidemiologist, and geneticist, professor at Harvard Medical School and a professor at the Harvard School of Public Health. And at Mass General Hospital, he's the director of the Center for Precision Psychiatry, among other roles. We talked about resiliency, what it is and isn't, mental health research, and what do we owe each other when we're thinking about mental health and trauma. I think you're really going to enjoy this conversation. Jordan, thanks for being here. I'm so excited to get you on my podcast.
Thank you, Manya. I'm so excited to be here.
The first question I ask all my guests before we dig into the topic is, what's one thing you have done in any area of your life that you never thought you would do?
One, there's so many. Practically my whole career is maybe the answer to that. But I don't know, does appearing in a rap video count?
Oh, that totally counts.
Okay, I'll go with that.
How did that happen?
This was a while ago. A friend of mine who was directing video, who later went on to become a Hollywood director, invited me to participate. We were both, I was a rap fan, and yeah, it was totally fun.
Oh, that's great. And
I played an uptight record executive.
Okay, cool. Did that feel like a stretch for you?
Not really. Uh, there was minimal plot, so
Yes, yes. Well, true for a lot of music videos. Just enough to hold together so it makes sense, potentially makes sense to the listener.
right, exactly.
Interesting. Okay, I never would have pictured that.
There you go.
Very interesting. Okay. Well, I wish we could go down that path, but we are actually talking about resilience and research and mental health. So we have to go off that a little bit. Let's start by the name of my podcast is Notes on Resilience. You may or may not know that I have a well-documented love-hate relationship with the concept of resilience. But I'm curious, when you think about it, what do you mean when you talk about resilience?
I think to me the big sort of distinction to make in terms of how people sometimes think of this, and how at least I think of it, and I think many people in the mental health field think, is that it's not the absence of susceptibility to stress. It's not the absence of, mental health problems or something like that. It's really about adapting in the face of adversity, and uh, trying to return to an adaptive or even flourishing state face of adversity. So it's not steeling yourself and just having grit and avoiding any kind of impact of adversity, finding ways to adapt and to emerge and to even grow in the face of adversity.
Okay. I love that you're using the word adapt. something I myself said, and I know other survivors in other cases have said, we very much say we want to get back to the way things were before. So 5 minutes before, 5 days before the thing, whatever it was, happened. And that's not really possible, is it?
Yeah, I think typically it's not because often if there is a traumatic event, something about the world has changed in a fundamental way. You are often not the person you were, and the circumstances are not necessarily what they were. And there's a certain degree in my saying it's about not just avoiding susceptibility to stress. It's partly about normalizing the fact that so many people experience substantial adversity and trauma and difficulties in coping with that or in adapting to it are expectable. And certainly distress is expectable. And finding a path forward in the face of that is often a process that takes some time. Some people are more vulnerable than others to having that process be a very difficult one, or even to experiencing stress related disorders. Other people find, for various reasons, that they experience a sense of growth. And many people, what we sometimes call post traumatic growth, but many people find ways to either adapt to the changes that have happened and maybe in a way that is different. The world is different. There's often no denying you're the victim of a natural disaster, for example, and your home has been destroyed and you're not knowing where to go. I mean, the world is a different place. So, yeah.
One of the things that has shaped my direction after the bombing is the lack of acknowledgement there was for those of us with mental health impacts. And I'm curious, why does that matter? Why does it matter that it's kind of publicly acknowledged or that leaders recognize that this is what's going on with folks who are dealing with a trauma?
Yeah. That's such an important question. I think it matters in a couple of ways. It matters for those who have experienced the trauma or a crisis. I think acknowledgement really, validates the reality that people experience and being able to say, I see what you've lost. This is devastating, or I see how painful this is. It communicates a sense of understanding, dignity, belonging, rather than sort of trying to minimize. Also, I think, from the perspective of those who are trying to help or leaders in organizations, responsibility begins with sort of naming what has happened and acknowledging what has happened in circumstances where there may be something that was harmful, that was about the environment that perhaps somebody is in, or maybe there's a leader in an organization. I think that that is an attempt to sort of be to take responsibility, to be empathic, certainly in the mental health community and mental health providers. I think that is one of the essential things that we aspire to do, is to be empathic, to recognize the pain that people may be in and have experienced, not to minimize it, and to meet people where they are.
As you're talking, I'm thinking that my own experience and those of other folks have shared with me that the mental health community, the social work community, the victim services community, these were where we found support. These were where we found people who understood what was going on. And you use the word expectable. These were folks who expected that this is what was happening and were there and with open arms being supportive. I maybe this is the cynic in me, but I don't see that in the larger community where there is that understanding and that empathy from leaders. And to me, it comes back to responsibility. Again, the cynic in me says, we're not going to acknowledge this because then that means somebody might think we're responsible. Curious your thoughts on that.
Yeah, I think I've seen what you're describing. And I think that, there are a couple of reasons, perhaps. One is people being concerned that they might be held responsible if they acknowledge, that something terrible has happened either under their watch or even if it's peripheral to their perceived responsibility. Another is people often feel unprepared to be in a position to respond to people who have gone through something really terrible and extreme. Many people just haven't developed the language or how to express that, and maybe worry that they're going to fall short. We think we encounter this in the world of suicide prevention, where there's a real reluctance sometimes to ask people about how they are doing, because you're worried if you get the answer that they are having suicidal thoughts, you don't know what to do with it. It can be overwhelming. I think there are many reasons that can happen. I think people, unfortunately, overestimate the problems and underestimate the benefits of frankly being empathic, acknowledging somebody's experience. And if you are in a position of leadership in an organization, not only acknowledging and making it clear that you understand what's going on, but actually moving beyond that to say, and here's what we're going to do about it. Here's the concrete change that we're putting in place. When people see that they are seen, when people experience that they're seen, there's some empathy and there's a commitment to do something about it when that's possible. It's not always possible. I think that goes a long way, and people's concerns about we're going to somehow be held responsible underestimate the power of simply connecting with people. It goes a long way to having people not only recover themselves, but to develop trust. And this happens in the medical world too. There used to be a sort of unspoken, perhaps, or even sometimes maybe spoken concern that if you acknowledged a mistake, it would greatly raise the legal liability. And even if there was no malpractice, essentially. And in fact, it turns out that as I understand it, at least, that's not only not true, but it raises the liability to minimize mistakes. People feel like you're not being transparent, or doesn't mean you have to say that I'm to blame, because maybe you're not, but that these terrible thing happened. Here's here's what happened, and here's what we're going to do about it, and even an apology goes a long way.
Right. I've experienced that in my own life, not a medical mistake, but instances where when someone just acknowledged what happened, that's all I needed. Nothing else had to happen, but until they acknowledged it, it was as if they were, I don't know, making it seem like I imagined it or that I had somehow made this thing up. You're like, just admit what happened.
Right. And it so compounds the burden for those who have experienced these things, because not only are you dealing with the emotional aftermath or physical aftermath of some event, but you're now sort of being turned away as you try to connect with other people, or having to bear it, or feeling like you have to bear it on your own, which we know actually is a detrimental thing.
Right. In your work, you do a lot of research to try to understand some of these factors that contribute to developing PTSD, to all these other things. And that seems like quite a responsibility.
Well, it is a difficult task for many reasons, actually. One, because of the complexity of understanding things like how our brains and minds and bodies work. Then also trying to find solutions. It's complex because the research world itself is often challenging. People often don't understand sort of how research happens, both in terms of how it gets funded and what's involved in doing this kind of work. But I will say that I think it's sort of a two-sided story of tremendous progress and frustrating difficulty in changing the status quo, and actually providing new innovations to folks, to patients, families, communities. But I always say, as others often do, that research is hope. This is the way that we move forward and do better. And that's why for me it's feels like maybe the most important thing I can do. I also am a practicing clinician, so I work with people day to day, but the ability to sort of impact the future is a real motivator.
Hi, it's Manya. You're listening to Notes on Resilience, conversations about leadership, recovery, and how we show up in the difficult moments. If something here hits home, or if you're navigating a crisis, or you're seeing something in your team you want to talk through, I'd love to hear from you. You can get in touch at my website, manyachilinsky.com. Now, back to the episode. Right. You're doing both. You're helping people in the moment and you're working to build a better future. Well, mental health is such a, I don't know, it seems so variable because it's so personal and you can't see it. And you have to rely on people either telling you what's happening or being able to interpret some types of behavior to understand. So I just find fascinating the work that you do both as a clinician and as a researcher because of that, because I think it's so difficult to, and even if you find the answer, not everybody's going to believe that's an answer.
Right. And it probably isn't an answer for everybody. I mean, in rare cases, we find a basic foundational fact that changes the game. But I think you're right. I mean, one of the particular challenges in mental health and in mental health research and in mental health practice is that it is very much about things like language and relationships and complexity at a level that is not only is, for example, the brain complex, but we exist in a social situation that's complex. And I think the field is starting to embrace that complexity rather than purely reducing it to something that we can study in one factor at a time. I think that's an important development, but it does make it challenging. Even our diagnostic system, in psychiatry, which people will probably know is kind of best known through the DSM, the Diagnostic and Statistical Manual, which provides criteria for psychiatric disorders, is designed to not focus on causes. I think appropriately in some ways because it would have been premature in defining these things to sort of assign what the cause is when we don't know. And in fact, PTSD and substance use disorders are two of the rare examples where a causal factor is actually in the criteria. A traumatic event is in the criteria. That's not true for depression or anxiety or schizophrenia or anything like that. But it's also a consensus of experts. What makes something a disorder? At what point does it go from being, say, normal variation in or expectable outcomes to something that we would consider could benefit from treatment and so on? So that in itself makes it difficult. Yeah.
That's interesting. You mentioned the concept of disorder, and I have heard arguments that PTSD shouldn't have the D at the end. It shouldn't be post-traumatic stress disorder, that the behaviors that you're seeing from someone are natural response to going through the trauma. I'm curious what you think about that.
Yeah, I understand that perspective. I think sometimes we attach a lot of importance to words for good reason, but sometimes people will say post-traumatic stress syndrome or simply post-traumatic stress. I think the reason that we think of disorder as having some value in the name is that it corresponds to what we think of in general about defining psychiatric disorder, which is not simply that you have symptoms or distress or even severe symptoms, but that it is really impairing in a consistent way and interfering with life and causing you great harm or impairment or disability. And when it crosses that line, which again, of course, is a judgment call for both the person experiencing it and perhaps the mental health provider, that's when we think of disorder in general. But it is true, it's absolutely true what you're saying, which is that it is sort of normative after a traumatic experience. There's nothing unexpected that people would have stress related responses, even severe ones, insomnia, hyper arousal, periods of depression, anxiety, etc. And everybody has probably a different time course of how that then moves on from there. And so I think we, to some extent, overvalue the focus on how we describe our diagnostic labels. It causes a lot of controversy, but I think in the end, it's about how do we ensure that we are all talking about sort of the same thing. And secondly, when does it become something that requires treatment or somebody wants to seek help for? There's also these sort of prosaic considerations about when does it get reimbursed for treatment, what services become available when you sort of quote cross that line. So it is a complicated sort of sociological phenomenon to define disorders. But I think for me, the big thing is, is this interfering substantially with your life in a way that we wouldn't have, that first of all, you think is beyond what is tolerable or is impairing, and that we might be able to do something about that's helpful.
Right. As you were talking, I was thinking of the concept of stigma
Yeah, I was just
because
thinking about that too.
not wanting to say something as a disorder, I think there's some fear. I hate that I had PTSD. I all of the normal reasons, but I also hate it because even though I know it wasn't my fault, it still feels like I still feel that stigma about it myself. I don't even want to say it was a disorder because then that means there was, I don't know, that says something about me that I don't like.
Well, it's interesting. I think you're right. It also goes back to what you were raising in the very beginning about acknowledging. One of the things about acknowledgement and empathy is that it reduces stigma. I mean, I think when people welcoming of other people's experience, that reduces stigma. In this context, it's ironic or striking that we have the degree of stigma that we have for something that is so mental health conditions as we recognize them or mental health struggles are so almost ubiquitous. And yet there is this stigma. We don't, I would imagine that if you had asthma, which is thought of as a disease, right? You wouldn't have that. It wouldn't reflect on your person in the same way, or you wouldn't worry that people thought it reflected on your person could and your capabilities as a human being. And that is something I think we need to continue to address. I think there's a lot of progress in some ways. I think there's also some backsliding in some of the ways we talk about mental health in the media, social media, in some corners that I worry about a little bit. But I think overall, and particularly among younger people, I think there is more of a sense of this is not something taboo to talk about.
Hmm. I do like that. And I have noticed that, especially among younger people. And I appreciate that. And I love that we're moving in that direction and wish we were moving a little faster. What do you think we owe each other after tragedy in terms of people's mental health?
We being everybody, the
We
people
being everybody. Yeah.
experiencing the tragedy, the people who are not experiencing it directly, but is that what you mean?
Yeah, I guess that's what I mean. Or how do you want to answer the question?
Yeah.
Who?
Okay. I think we owe each other, first of all, I think we owe each other an empathic approach to other people. We owe each other at a sort of more structural level. I think we each other access to help. We are currently experiencing a tremendous shortage of mental health care, and that's putting aside the problems of reimbursement for care and so on. Well, it's not actually putting aside; it's related to that. But access to help doesn't have to be in a medical setting. We owe a an acknowledgement, I think, of what's happened and not sort of trying to minimize or certainly make those who have experienced trauma feel excluded in some ways. I think we need to perhaps certainly dispel stigma. I mean, that's sort of almost goes without saying, but maybe it doesn't go without saying, including the more subtle forms of sort of, well, walk it off, basically. Uh, and, it's all about grit and implying in some way that you really should be getting over this at some point or something like that. And I think we, again, at a higher social level, owe an examination, depending on what the event is, an examination of what are some of the social factors or structural factors or things that may have contributed that we may need to start to address in a different way. You know, this, there's a fierce debate, of course, about guns, firearms, and I don't see that subsiding in the immediate future, but it's a really important one. We know that, firearms are responsible for most, or the most, lethal form of for suicide, and we avoid some of the tragedies that we see happening way too often.
Right. And now we're talking a mix of social factors and all these other things you mentioned, and then add on to it that political layer where people have particular agendas. And sometimes these things can feel intractable.
We were just having a conference the other day, and I think the phrase was that the speaker mentioned was, optimism is maybe is a moral choice. That is, even in the face of things that seem intractable, we have to make a moral choice to not give up.
Wow. Well, we're getting close to the end, but what is one change you would want to see in any way you can think of it that would make the most difference for our mental health and well-being?
Oh, that's such a huge question.
It is.
To boil down to one thing. I mean, I think that I guess I would think of it in two large areas. So I'm not going to say one thing, but I could maybe reduce it to sort of two big things.
Okay.
One is, but now I'm thinking of 12 others. But one is immediate response to seriously addressing mental health issues that people have. And that is partly an access problem. I think we have not adequately solved that problem of getting people the help or making it available, the help that they may need now. Reducing stigma is a part of that. So I'm throwing in that a little bit. And the other thing, this might sound self-serving, but investment in the future and research. I mean, things are only going to stay the way they are if we don't try to learn more, change things. It's not necessarily biological research. I mean, that also involves research in social determinants of health, research in psychology, psychiatry, what treatments are effective. That is the hope. I really believe that. We absolutely need to invest in it, and the return on that investment is a different future.
Jordan, I could talk to you forever, as you know, as we have in other circumstances. Thank you so much for your time. Can you just tell our listeners a little bit about yourself, of your long list of things that you do?
What I'm currently doing,
Yes.
I am direct. I'm at Mass General Hospital where I direct the psychiatric and neurodevelopmental genetics unit in our Center for Genomic Medicine. I also am the director of the Center for Precision Psychiatry, and I am co-director of the Center for Suicide Research and Prevention, along with my colleague Matthew Knock. And a lot of my work is now focused on using new tools, data-driven approaches to reduce risk and enhance resilience in many different ways. The motto or vision of our center, which has really become a guiding thing for me, is innovation to implementation. How do we focus on those areas where that require research and discovery, but that have a near-term possibility of really helping people with their current massive unmet needs, I think.
Right. Wow. Okay. Thank you very much, Jordan. It was such a pleasure to talk to you. I appreciate you being here.
It always is. Pleasure to talk to you.
And thank you to our listeners, and we will catch you at the next episode.